Today we're going to be taking a look at 5 practice chest X-ray questions using a structured A2E approach. The cases will be slightly easier at the start and then gradually become more difficult towards the end. Let's start with our first question, which involves a 58-year-old male who presents with a 3-day history of productive cough and fever. He has a background of well-controlled asthma, and we have our chest X-ray image here. If you want to, you can pause the video and attempt to work out the pathology in this case. The first aspect that we can assess is the quality of the image, and we do this by assessing a few different domains, including the rotation, inspiration, projection, and exposure of the image. Starting with the rotation first, we can see that the spinous processes are clearly well aligned in this case, so there doesn't appear to be any rotation either to the right or to the left. In terms of the inspiration, we can count around 6 to 7 anterior ribs on both sides, which is adequate to assess the lower zones of the lungs. The projection of the image isn't detailed on the scan, but we can make out the scapulae on both sides, which suggests that this is a posterior-anterior view rather than an AP view. Finally, we can make out the vertebrae behind the heart, which suggests that the exposure is adequate. Overall, the image quality appears suitable, and we can move on to the next step to assess the airway. This involves looking at the trachea first, where we can see in this case that there is a normal centrally located trachea without any deviation. We can also take a look at the hilum, which is the region where the main blood vessels of the mediastinum arise from. And in this instance, you can see that there's no obvious enlargement of the hilar regions, and the appearance is normal. Moving on to the breathing aspect, here we can assess the lung fields, and in this case we can see a right lower zone opacification, which isn't present on the left side. The remainder of the lung fields appear clear without any consolidation elsewhere. As well as this, we can also assess the pleura, and we can check for features such as pneumothoraces, which are absent in this case. Following this, we can move on to the cardiac aspect, and you can see that the borders of the heart are clearly visible with a normal heart size. The mediastinum also measures appropriately, and there doesn't appear to be any enlargement of this. Moving on to the diaphragm, here we can see that the right hemidiaphragm is correctly above the left, and there doesn't appear to be any pneumoperitoneum present. We can also check the costophrenic angles, which are the regions between the diaphragm and the chest wall. And in this case, you can see that there's a little bit of shadowing on the right side. Finally, checking the image for any extra features, we can't see any bony injuries, medical devices, or foreign bodies on the scan. Putting all of this information together, it appears that the main finding in this case is the right-sided lower zone opacification, and this can be representative of either a consolidation or even a possible effusion. This is where we can use the history to connect the final dots together, and because it's quite a short history with a fever, it's more suggestive of a right-sided pneumonia as opposed to an effusion. Let's now move towards the second question, which involves a 65-year-old male who presents with shortness of breath and a non-productive cough over the past 4 months. He smokes around 20 cigarettes per day, and we have the chest X-ray image here. Again, if you want, you can pause the video and try to work out the diagnosis in this case. Okay, so working through this case, we can use our structured A2E approach and start by analyzing the image quality first. Just like in the first case, the spinous processes appear to be well aligned, and there doesn't appear to be any rotation towards one side or the other. Likewise, there appears to be more than adequate inspiration, with around 8 to 9 anterior ribs visible on both sides. The projection of the image isn't listed on the scan, but we can make out the scapula, especially on the right side, which suggests that this is a PA view. Finally, looking at the exposure, we can again make out the vertebrae behind the heart, which is adequate for interpretation. Having assessed the image quality, we can move on to look at the airway next, and we can see that the trachea appears to be centrally located without any obvious deviation. The hilum also has a normal appearance without any obvious enlargement on either side. Following this, we can assess the breathing aspect by checking the lung fields. At first glance, it appears that there might not be anything abnormal in this case, so there's no evidence of any sort of focal consolidation or pacifications in either lung fields. However, one more subtle abnormality is that the lung fields appear to be hyperinflated or hyperexpanded, which means that we can actually make out more of the lower zones than we typically can in normal individuals. While we're checking the lungs, we can also check for any pleural abnormalities, and there don't appear to be any pneumothoraces or effusions present. Turning towards the cardiac aspect, here we can make out the borders of the heart quite clearly, and there doesn't appear to be any evidence of any cardiomegaly or other cardiac pathology. Likewise, the mediastinum appears to be normal in width at less than 8 centimeters in diameter. Because there's no evidence of any cardiac pathology, we can move on to assess the diaphragm. Here again, there is a bit more of a subtle abnormality present, which is that the diaphragm appears to be much more flat compared to usual. This suggests that the hyperexpanded lungs are actually pushing down on the diaphragm, causing this flattened appearance. The remainder of the diaphragm is normal, so there's no evidence of any pneumoperitoneum, and the costophrenic angles also appear to be normal without any blunting between them. Finally, checking for any extra features, there's no signs of any bony injuries, medical devices, or foreign bodies on this scan. Piecing all of this information together, we can say that the main findings are the hyperexpanded lung fields and the flattened hemidiaphragms on both sides. Combining this with the heavy smoking history, we can say that the most likely diagnosis in this case is a chronic obstructive pulmonary disorder, or COPD. Let's now move on to the third question, which involves a 40-year-old male who's brought via ambulance to A&E with shortness of breath following a high-speed motorcycle accident, and we have our chest x-ray image below. Again, feel free to pause the video and try to work out the pathology in this instance. I'll also zoom in just so that you can see the lung fields in more detail for this example. Following our A2E approach, we'll start by assessing the image quality, and this is one of those cases where it's really important to assess the quality first. This is because if we have a look at the spinous processes, you can see that they're not in a straight line, and they're kind of curving towards the right. We can also corroborate this with the medial aspect of each clavicle, and you can see how the right clavicle is a bit further away from the spinous processes compared to the left, suggesting that the image is actually rotated towards the right-hand side. In terms of the inspiration, we can make out around 6 anterior ribs on both sides, which is adequate for assessment. In terms of the projection of the image, this is actually detailed in the top left-hand corner of the image, so we can see that the patient was in a supine position or an anterior-posterior view. Finally, taking a look at the exposure, there's no evidence of any underexposure or overexposure, and we're happy that we can assess the rest of the image. This brings us on to the airway, where we can see that the trachea in this case is quite significantly deviated towards the right-hand side. And although we know that the image is slightly rotated towards the right, there does appear to be extensive deviation despite this. The hilar regions are a bit more difficult to make out, but there doesn't appear to be any obvious abnormalities present. Moving on to the breathing aspect, we can check the lung fields, and the most prominent finding in this case is this large left-sided blackout, which is suggestive of air in the pleura. It's a bit harder to make out the right side of the lung field due to the rotation of the image, but we can't see any corresponding blackout on that side. Based on this, we can say that the blackout on the left side is most likely representative of a large left-sided pneumothorax, meaning that there's air in the pleural cavity which is driving the pathology. After this, we can try to assess the cardiac features, and we're a bit more restricted here because of the view that's being used. So while we can assess the cardiac borders, it's much more difficult to make an accurate prediction about the heart size, because the anterior-posterior view will exaggerate the heart size, and the same also applies to the mediastinum as well. Aside from the cardiac features, we can have a look at the diaphragm, And in this case, we can see there's normal positioning of both hemidiaphragms with no pneumoperitoneum present. The costophrenic angles also appear to be normal without any blunting on either side. Finally, it's really important to take a look at extra features in cases of trauma. And in this instance, there are actually multiple bony injuries seen. So there are left-sided posterior rib fractures in the 3rd, 4th, and 5th posterior ribs. Just to show this more closely, we can zoom in and see how there's discontinuity between the ribs at some of these points. As well as this, there does appear to be a left-sided clavicular fracture too, where you can see a bit of loss of continuity again. Aside from the bony injuries, we can comment on any medical devices, and in this case we can see some external ECG leads present. Summarizing all of this information, we can say that we have a left-sided pneumothorax with significant tracheal deviation towards the right, as well as some left-sided rib fractures and a left-sided clavicular fracture. For the bonus point, we can link everything together, and what's likely happened in this case is that the trauma caused rib fractures, and the rib fractures inevitably caused a left-sided tension pneumothorax. Moving on to the 4th case, here we have a 65-year-old male who presents with shortness of breath over the past 4 to 5 months. His symptoms are worsened when lying down, and we have a chest x-ray image here. Just like before, feel free to pause the video and attempt this question. Working through this one, we can begin by assessing the image quality, and in this instance everything seems okay, so there's no obvious rotation of the image because the spinous processes are aligned. There's good inspiration, so around 6 anterior ribs visible bilaterally. The projection in this case is a posterior anterior view because we can see the scapulae projected, and finally the exposure seems adequate because we can make out vertebrae from behind. With the image quality intact, we can move on to assessing the airway next, and we can see how the trachea is centrally positioned without any deviation to either side. In terms of the hilum, there is a bit of perihilar shadowing, so a bit of haziness on both sides surrounding the main vessels, and whenever we have this sort of pattern, it's sometimes described as a bat's wings appearance. Keeping these hilar features in mind, we can move on to assessing the lung fields next. Here we can see quite a bit of haziness surrounding the main pulmonary vessels, and this is often referred to as upper lobe diversion. The reason we might see this is due to pulmonary congestion, so if there's an element of fluid overload, the excess fluid can sometimes redistribute itself and end up entering the main pulmonary vessels, and this is what we see on the scan. As well as this, there does appear to be some generalized haziness surrounding the lung fields. So for example, we can see some increased haziness on the right-hand side, which is often referred to as interstitial edema. If we look really closely, we can also see some features known as curly B lines, and these are basically horizontal lines that can be seen inside the lung fields, where these are representative of either fluid in the lung or thickening of part of the lung. Moving on to the pleural aspects, we can see that there's no obvious pleural collections, but there is a little bit of haziness surrounding the left lower zone. Following this, we can take a look at the cardiac features, and if we draw the outline of the heart in this case, you can see that it does appear to be slightly enlarged. In fact, if we were to divide the cardiac width by the total thoracic width, you can see that we get a value of greater than 50%, which is indicative of cardiomegaly. We can also take a glance at the mediastinum, and there doesn't appear to be any obvious widening in this case. The aortic notch also appears to be normal without any signs of enlargement. Turning towards the diaphragm, here we can see that the diaphragms are correctly positioned without any pneumoperitoneum. While checking this, we can also have a look at the costophrenic angles, and here we can see that there's a little bit of mild blunting on the left side, especially when comparing it to the right. Scanning the X-ray for any extra features, we can't really see any medical devices, bony injuries, or foreign bodies in this instance. To put all of this together, we can see that the main findings are this interstitial shadowing, upper lobe diversion, and significant cardiomegaly. All of these features point towards the diagnosis of congestive heart failure, which explains the symptoms of shortness of breath when lying flat. Let's now take a look at our final case, which involves a 40-year-old male who presents with a 3-week history of fever, cough, and night sweats after a trip to New Zealand. He has a background of rheumatoid arthritis and is on regular infliximab for this. And we have our final chest X-ray image here. This case is a little bit more challenging, so feel free to pause and attempt to work out the diagnosis in this case. Okay, so working through this one, we can start with our usual drill of assessing image quality first. So we can see that the spinous processes are well aligned without any rotation towards one side or the other. The inspiration of the image also appears to be adequate, with around 6 to 7 anterior ribs visible on both sides. We don't have the projection listed on the scan, but we can see the scapulae projected through, suggesting that this is a PA view. And finally, we can see that the exposure of the image is adequate with vertebrae visible behind the heart. As the quality of the image is appropriate, we can move on to assessing the airway next, and here we can see that the trachea is centrally positioned without any obvious deviation. One of our key findings is actually in the hilar regions, so we can see that there's quite a lot of hilar enlargement, especially on the right hand side, which is suggestive of some form of pulmonary pathology or lymphadenopathy. Keeping this in mind, we can move on to examine the breathing, and this can be quite difficult to spot initially, but there do appear to be small dots present in both lung fields, which are referred to as micronodular opacifications. Just to take a closer look at these, we can zoom in and see multiple pinpoint-shaped dots present throughout both lungs, and there doesn't appear to be any preference for which zones are affected. Whenever we see lesions like this, we can be suspicious for pathologies such as infection or inflammation. Having assessed the fields, we can also take a look at the pleura, where we can't see any evidence of any pneumothoraces or pleural effusions. In terms of the cardiac aspect, we can see the borders of the heart clearly, and there doesn't appear to be any evidence of any cardiomegaly present. The mediastinum also appears to be of normal width, and there are no signs of any aneurysms or dissection. Progressing onto the diaphragm, we can see that both hemidiaphragms are situated appropriately without any evidence of pneumoperitoneum. The costophrenic angles also appear to be sharp, and there's no apparent costophrenic blunting. As always, it's important to check for any extra features, but there don't appear to be any present in this case, so we can move on to making our final diagnosis. In this case, the main findings appear to be bilateral multinodular opacifications and bilateral hilar enlargement. This is where it becomes crucial to combine the imaging with the history details, especially because we know that the patient is on long-term immunosuppression. This increases their predisposition to having atypical infections, or infections which are more severe compared to usual. Combining all of these features together, this points towards a diagnosis of miliary tuberculosis. To finish off, we have a summary slide here which outlines the A2E approach for interpreting a chest X-ray. I hope you found this video helpful, and I'll see you in the next one.